As humans, we're afraid of diseases, but have you ever been afraid of becoming resistant to the drugs that treat them? In the EU alone, an estimated 25,000 patients die annually from an infection from multi-drug resistant bacteria within a medical setting. Not only is bacterial resistance attributed to the use and abuse of antibiotics, an inefficient economic infrastructure also means that too few antibiotics are being produced. Today's report aims to explore, analyse and suggest how stewardship and the reworking of the pharmaceutical market can make antibiotic resistance less of a threat to the human race. Antibiotics are medicines used to combat bacteria. They have played an important role in eradicating once untreatable diseases, preventing infections at surgical incisions, and turning deadly ailments into manageable health problems. Antibiotic resistance is the ability of bacteria to grow in the presence of an antibiotic. Those that resist and survive the drug multiply and convey resistance onto the next generation of bacteria. So why is this a problem? According to Steve Gilman, Chief Scientific Officer for Cubist Pharmaceuticals, the resistance rates we saw in the 90s were at 10 to 15%. Now it's up to 60% in hospitals. Antibiotics are regularly taken to reduce the risk of bacterial infections after surgeries. In a world where antibiotics do not work, post-operational infections and death will soar, making many procedures such as hip operations too risky to undertake. It's hard to estimate what could be an unimaginable cost to society. So how has this become a problem? Antibiotic resistance in itself is not a new issue. It is a naturally occurring phenomenon, which we will always be fighting. The problem stems from the overuse and abuse of antibiotics, increasing the rate at which resistance occurs. It is important to note that any use of antimicrobials, even if appropriate and conservative, contributes to the development of resistance. The ICU book, A Practical Guideline for Medics, states that the first rule of antibiotics is try not to use them, and the second rule is try not to use too many of them. However, there is a widespread misconception about antibiotic use by the average citizen. Many are used to treat symptoms or diseases that do not need antibiotics to resolve, an example being viruses such as the common cold. This is especially pertinent in many countries where people are able to purchase antibiotics over the counter and take them without appropriate medical advice. Inappropriate use and prescription of antibiotics contribute to the development of resistance, with half of antibiotic use being unnecessary or inappropriate. This includes not taking antibiotics as prescribed, skipping doses or saving some for later and not completing the course. An additional problem is the lack of new drugs currently being produced to combat antibiotic resistance. As seen in the chart, between the 1930s and 1960s, more than a dozen new classes of antibiotics were developed, but only 2 new classes have been discovered since then. In fact, by 2004, only 1.6% of drug development among the 15 largest pharmaceutical companies were for antibiotics. This is an issue because the pool of drugs that we use to treat disease is continually being reduced due to antibiotic resistance. The reasons for the lack of new drugs can be explained from an economic standpoint.
Like all businesses, a pharmaceutical company's decision to invest in an antibiotic research resides in the potential returns. Antibiotics are different from other drugs. Whereas long-term diseases like cancer are treated over decades, an antibiotic can treat a bacterial infection within a relatively short period of time. Big pharmaceutical companies therefore have a greater incentive to produce drugs that treat long-term diseases as they provide higher returns. 11 years is the amount of time it takes to bring a drug to market. About 80% of the drugs emerging from labs fail in safety or efficacy testing. Companies also face challenges such as the risk that a competitor can produce a drug sooner, gaining a precious share of the market. Additionally, antibiotics only have a 5-year period of exclusivity, making it difficult for companies to maximize their returns. This is especially relevant if authorities insist the antibiotic remains in reserve. In fact, the research and production of new antibiotics may also give rise to negative externality. More antibiotics in the market results in greater prevalence of resistance in society. The problem of resistance itself causes antibiotics to have shorter lifespans, increasing the uncertainty of monetary returns for firms. Since antibiotic resistance is a problem we will always face, we need to create a more efficient infrastructure to support the production of antibiotics in the future. Professor Laura Piddock tells us about moving away from using big pharmaceutical companies to produce antibiotics.
So the whole antibiotic pipeline from discovery to inpatients as a licensed drug is about 10 to 11 years. In part, that can be reduced and has been reduced with using much smaller clinical trials, such as the GAIN Act in the US, which facilitated the FDA as approving drugs for a much smaller indication on medical need. But what's really going to improve things is if we can get the discovery and research part, the beginning part of the pipeline, accelerated. That really has moved out of pharma. Most new discoveries that have made it to drugs in the last 15 years as antimicrobials have come out of either universities or start-up, spin-up companies out of universities, small, medium enterprises. The problem is there's insufficient funding for the sheer number of programs of research that we needed to provide the drugs that eventually go into clinical trial. So what really needs to be done is not reinvestment in pharma, because they're not going to be discovering and research. The investment is needed for basic research in a totally different way to the way we've had it.
Has the commercially driven market and short-sightedness led to a paradigm shift in the production of antibiotics?
So commercially, the low-hanging fruit has been picked. The things that were easy to commercialise have definitely been done. And that's one of the problems, because the whole pipeline from discovery right the way through to making the drugs has been seen to be the remit of the pharmaceutical industry. Now that paradigm has changed and is continuing to evolve, because even some phase 1 and phase 2 clinical trials are now funded by governments, and that will continue to evolve and change, then we will allow much more innovation. And innovation in universities and small medium enterprises is much easier to do when you're not commercially driven. You know, so researchers can sort of give free rein to lots of different ideas. There are lots of new things coming along. We saw the whole new class of antibiotics described in January in Nature. So we know there's lots more to discover. It may not be commercially viable, and that again then will have to be addressed. Well, how do you invest in this area for the greater good? Is it simply going to be governments funding this and therefore ultimately making it just as a product right at the end? That's all companies' role will be. We don't know how it'll end up.
Okay. Clearly the paradigm has changed and we need to invest in small and medium enterprises. Governments also need a greater involvement in assuming some of the risk of production.
Well, one way to overcome the problem about the term of effectiveness would be for the government to say, look, don't worry about how long the drug will last. We'll take that risk. We'll buy the drug off you. We'll guarantee you a certain price and a certain quantity so that you know that you have some degree of certainty that if you invent something that you will get the drug. Now, it might be that the drug only turns out to be effective for a short period of time, but the government is now assuming that risk. They've stockpiled the drug that you've produced.
Delinkage refers to removing the link between sale volumes and funding research and development. This provides a solution, but ultimately we need to find a balance between public and private interests to ensure maximum investment in research. Additionally, because the trickle of new effective antibiotics entering the market cannot compete with the pace at which bacteria become resistant to the drugs treating it, research and development funding must be increased. According to the National Institutes of Health in the United States, only $1.7 billion goes into antibiotic research and development, whereas $26.5 billion goes towards the production of cancer drugs. It is almost ironic that so much money is invested in cancer drug research, since the risk of patients dying from infections from the surgical removal of cancer cells could become higher than the number of people dying from cancer itself if resistant rates continue to increase. Antibiotic resistance is not being treated as a big enough issue. So what can we do to solve the problem? Back to you, Josh.
Although economics can provide a long-term solution for the lack of drugs, resistance is caused by the use and abuse of antibiotics. Humans then can only be saved if the global community comes together in an effort to enact stewardship programs. Stewardship is where we use antibiotics only as a last resort and when absolutely necessary. A key component to this solution is the safeguarding of new antibiotic use through regulation. We believe that the best way to enact stewardship is to allow governments to have greater control of antibiotics in the market. So what happens when we have two drugs available at the same time? Should we use them in sequence or in parallel?
I gather that the research is saying that you're better off to use them in sequence. In other words, you use one drug for now, and over a period of time, when the resistance to that grows, then you bring on the second drug. So if a government is taking over the control and then bringing the delinkage stewardship, it can buy up 2 lots of drugs and use them in sequence, whereas if it was left to the market, they would want to use them in competition with one another. So stewardship has big benefits there.
Existing antibiotics are used within the EU only for severe infections and generic first-line therapies. Also within the UK, antibiotics are only allowed to be prescribed by medical practitioners or pharmacists. However, the greatest barrier we face is poor global cooperation, with illegal over-the-counter antibiotics still existing in many countries and potentiating resistance. Public awareness campaigns such as Antibiotic Action and the GAIN Act have helped educate the average person to use antibiotics appropriately, so that the rate of resistance is reduced. However, ideally, these regulations and awareness campaigns need to be implemented globally. We therefore place the task of saving humans from antibiotic resistance not in the hands of government, but individuals. As Laura Piddock states,
no, I think the general public have to be involved, in the same way as they've been involved with cancer research. There is no single charity for antibiotic research or infection research. There's lots of little medical or scientific societies that fund little bits of research, but research in the main is funded by government funders, both here and abroad. So the only way you're going to get that funding increased and increase discovery is the general public,
we can act collectively to encourage governments to achieve the economic reforms necessary. Furthermore, people can help tackle resistance by fully completing the prescription of drugs, never using leftover antibiotics and only using them when prescribed by a doctor. As we mentioned earlier within our report, our role as consumers is growing stronger. If we have a reduced expectation to receive antibiotics, then there is less pressure on the doctor to prescribe. As a consequence, encouraging stewardship. Antibiotic resistance is a much bigger issue than many of us realise, with 3 million people facing death by pneumococcal infections. We therefore need to remodel the economic infrastructure, increase funding in antibiotic research, and encourage global cooperation and stewardship. Together, we can take responsibility and take action. So what will you do to save humans?